Abraham from the London Diabetes Centre. Today I'm going to talk about insulin, given that we are so close to its centenary. It was January the 11th, 1922, almost 100 years ago, when insulin was first successfully used in the treatment of diabetes at the Toronto General Hospital. Professor MacLeod, Frederick Banting, Charles Best, and James Collip were extracting insulin from pancreatic extracts and showing success when these were injected into dogs that had been given diabetes. By December 1921, they had purified these extracts and showed that they worked in human diabetes. A month later, 14-year-old Leonard Thompson was given purified insulin extract. The enormous success of that treatment reached London quickly, where Dr. R.D. Lawrence, who was a young surgeon at King's College Hospital, was slowly deteriorating with the then wonderful treatment of no carbs and weight loss. And this weight loss diet was very debilitating. He left London to go to Florence so that his family didn't need to see him die, and he wanted to be in a warm environment. While he was there, he received a telegram from his colleague, Dr. Geoffrey Harrison at King's College Hospital. "I've got some insulin. Come back quick. It works." Dr. R.D. Lawrence received his first dose of insulin at King's College Hospital on May the 31st, 1923. And his life was saved and his professional drive to help people with diabetes restored. He spent his life promoting the welfare of people with diabetes and founded what is now Diabetes UK. So just as I am humbled by the achievements of the scientists and the clinicians and the drive that has helped us over this terrible recent COVID pandemic, I salute the pioneers that 100 years ago brought the life-saving replacement of this essential hormone insulin into practice, the first of many other hormones that have enabled people with hormone deficiencies to lead normal lives. Since those days, we have tamed the use of insulin. We have insulins that last from 3 to 36 hours, and even weekly ones in development. We have insulins that come into action faster and more in line with the absorption of food. We have devices to give insulin from pumps and pens to patches, and we have detectors that can document and inform how much insulin was given and when. Wow. All this to tame the beast that is the most powerful way of bringing elevated glucoses down, but can go all the way to a low glucose, causing havoc and destruction and unconsciousness and coma. The nearest we have got to taming this bucking bronco are the insulin-glucagon combination pumps, which put out a little glucose-raising glucagon to match the maximum action of insulin and prevent hypoglycemia. For years, we had no choice. Type 1 diabetes was the only condition we could treat, and when it came to type 2 diabetes, it was metformin orally and then insulin, as there was nothing else available. Slowly, however, with time, other drug groups were discovered and used, and they were different. They all lowered the blood glucose to different degrees, but they worked in different ways. They had different benefits and side effects, and strangely, not all of them needed the pancreas to be effective. This was diabetes management without insulin. Insulin was not the only way to control the blood glucose. This has changed diabetes care in the last 10 years, particularly. It has made diabetes care more expensive, and many of the drugs we now use in more affluent countries are not available for the great numbers of people with diabetes across the globe. Let us first consider the advantages and disadvantages of insulin as a treatment. It is very powerful at lowering glucose, but has disadvantages in that it has to be taken by injection. It's got to be timed carefully. It causes hypoglycemia with effects on conscious mentation levels, and it results in weight gain. Is it always necessary? Well, in the past, when there were no alternatives, it was. And of course, it still is in type 1 diabetes, which is an insulin deficiency disease. But in people with type 2 diabetes who are overweight and have insulin resistance, there are alternatives. After a lifetime of diabetes, people with type 2 diabetes can become insulin deficient and need insulin therapy. But this should only be considered when deficiency has been confirmed with a blood test, as there are so many alternatives that may be more appropriate for a patient. There is this twilight zone, often lasting some years, where a patient with type 2 diabetes has deteriorating diabetes despite modest medication and attention to diet and lifestyle. And it often leads doctors to early and inappropriate introduction of insulin. Diet here is an important consideration. Start first to think about where diet and lifestyle play a role in the glucose control. Modification here can be of huge benefit. Then consider diabetes medication that aids weight loss and reduces appetite. When it is clear that this is needed, use other diabetes medication. Generally speaking, the first one to think about is the group of drugs called the Glp-1 agonists. Originally taken by injection daily and sometimes twice daily, and then weekly with better development of drugs, and now available in tablet form daily. These include drugs with the names Trulicity, Luxumia, Byetta, Bidureon, Victoza, Ozempic, and Rybelsus. What amazing names. They assist weight loss. They are the most powerful glucose-lowering option, yet they never cause a low glucose, and they additionally have benefits on kidney and heart. What is there not to like? In my opinion, if a patient is obese or has a history of coronary artery disease, it becomes mandatory. Even when insulin really is required to maintain excellent glucose levels, it allows the use of a single injection of long-acting insulin as a top-up only. Less hypoglycemia, more weight gain, better control. The GLP-1 agonist allows one to do without mealtime fast-acting insulin, so often the cause of hypoglycemia. And it's not the only alternative. The oral SGLT2 inhibitors, drugs with names such as Jardiance, Stelagro, or Forxiga, or Invokana, they also help weight loss and never cause a hypoglycemia. They reduce hospitalization from heart failure and are beneficial for patients with risks for heart disease. They too allow us now to help patients with diet and weight loss, improve their risks of future illness, and avoid hypoglycemia, while achieving glucose targets never possible in the past without severe hypoglycemia. In fact, if I get levels of HbA1c over 7%, I'm always criticizing myself for not enough effort in helping my patients. The costs of using insulin-sparing medication, such as the GLP-1 agonists, and the SGLT2 inhibitors are higher drug costs, more management time, and often a fair proportion of side effects. So they are not easy drugs necessarily to use without problems. This little talk was all about saluting the discovery and the use of insulin, which so dramatically transformed the life of people dying with type 1 diabetes. But we have not tamed insulin. We still use it, warts and all. Increasingly, doctors are looking at other drugs and their advantages, sometimes with and mostly without insulin, and achieving better outcomes and better tailored to the needs of an individual patient. Sometimes I feel like Picasso with a bigger and better palette to help my patients, allowing my diabetes care to be increasingly personalized to an individual patient's needs. So thank you, Banting, Best, McLeod and Collip and Lawrence, and thank you, all you first pioneer patients, for inspiring us. This is Dr. Ralph Abraham from the London Diabetes Centre.